Hi, this is Artur Zembowicz. I am currently in Needham, Massachusetts at my dermatopathology consultations office, and I am here with Dr. Dan Jones, who is dialing in from Cincinnati. And this is going to be the part 2 of the workshop on leukemic infiltrates, the diagnosis we don't want to miss, and with a focus on Blastic, Plasmacytoid, Dendritic cell Neoplasm. So I hope that most of you have had a chance to listen to Dan presenting the lecture last week. The objective today is to just to have more leisurely look at lymphoid infiltrates as we can see them in the skin in the context of dermatopathology, and allow us maybe to interact a little bit more and with you, and so we welcome your questions through chat. And so I think actually I should probably mention, if there are people who did not watch the part 1, that Dan is professor of pathology at Ohio State in Cincinnati, that we together were residents at the Brigham Women's Hospital. That's when we met, and then later went on to actually his first job was director of hematopathology at MD Anderson. Is that true, Dan?
Not director, but I was a hematopathologist.
Yeah, it was because I remember that because I was a junior resident, and I remember that Dan got.
I think Jeff Medeiros would not appreciate me saying I was director of hematopathology.
Yeah, because I still remember that it was just that I remember how impressive. I realized I must be in a good place. So when people leave Brigham Women's, they get this fantastic jobs like Dan did. I still remember that, you know. So whatever it was, it seemed very big for a junior resident. So yeah, and Dan was one of people. It was a group of people, but then also made significant contributions to describing BPDCN as the entity, and also, Dan looked at a lot of skins, both at the Brigham, I remember that, and then later at MD Anderson. So he's quite good dermatopathologist as well. So Dan,
Great, thank you, Artur. And I'm just going to start out here with a sort of iconic image just to make a few points. And you guys seeing my slides? I can't tell.
Yes, I can see you. Yeah, I can see you.
Okay, let me bring this up a little closer here so I can keep an eye on you guys. So this is kind of my iconic image, and it is actually a case of Blastic, Plasmacytoid, Dendritic cell Neoplasm, and make a few points that will kind of reinforce as we go through. Obviously, it's a bottom-heavy infiltrate, but it extends all the way up almost to the epidermis, perivascular, crush artifact, based on the edges of the biopsy here, clearly inducing fibrosis. And a really important thing that we'll go over in the next couple of differentials is essentially most leukemia cutis and dendritic cell neoplasm don't interact much with the epidermis. And as a result, if you see a lot of epidermal changes, epidermal involvement, in a newly diagnosed case, it's probably going to steer you in the direction of other types of tumors. So these are kinds of things we'll come back to as we look, and we'll get into the cytology of the cells quite a bit. Artur has some cases, I have some cases, but this is just to kind of get us started on the classic image that one imagines for that. So what I want to do is then talk about some cases which are not, but which are dense heme infiltrates in the skin that one can begin to wonder, could they be leukemia cutis? And let me actually just go to the lowest power of all so we can look at this lesion. And one of the things I think you see here is it's a pretty deep lesion, but it actually goes right up to the boundary between the dermis and the epidermis. We have parakeratosis, we have a regular epidermal hyperplasia, and as we'll see, we even have some focal infiltration into the epidermis, but very dense blue cells. And then as you go down, you see that as it's going deep, it actually tends to be hugging the adnexal structures, which is not a feature particularly of leukemia cutis, which tends to be perivascular rather than periadnexal. And let me just bring the light up here a little bit so we can kind of look at the cytomorphology of these cells. And so the first thing to notice, of course, is that we do actually have a Poitiers microabscess here. And then if we go look at the morphology of the cells, I've already, of course, indicated what the diagnosis is here. But you can see they're widely spaced. And one of the things we'll see about all the blastic infiltrates in skin is they tend to overlap and they tend to mold. And you can see in contrast, most cases of lymphoma in the skin are more dispersed. And as they get larger, of course, they're going to have more cytoplasm. So this is kind of an intermediate size. So this is a patient with longstanding patch stage who then is going into plaque and tumor stage MF. And this is kind of what it looks like as it's not yet fully transformed to large cell lymphoma, but is basically in that intermediate zone.
So Dan?
Yep.
Yeah, I think that's kind of a point that people will appreciate. As you said, that separation of the cells.
Mm-hmm.
Yeah, I just wanted to point out to that because what I listened to our lecture again from last week just to remind myself, and what I think is that in dermatopathology, when we look at the lymphoid infiltrates, we kind of dismiss to some degree the nuance of morphology.
Mm-hmm.
And you guys in HemePath, you observe all these differences that we don't. So if I have opportunity, I will be kind of stopping you and maybe just asking you to point out those little morphological clues that you see as a hematopathologist, and we sometimes don't see and don't appreciate.
Yeah, and so obviously, you don't have to go to oil. You can just do high dry. You get more or less the same thing. But as we talk today, these are widely spaced. But as we look at them, it's pretty easy to appreciate the true cerebriform cells, even in a case that's relatively poorly fixed. So that's really useful in all cases to kind of get an appreciation, as we talked about last time, of the level of irregularity which is acceptable in a benign infiltrate, and this kind of striation and folding that is really indicative in this case of mycosis fungoides. So that's what I always recommend. So then we look at another case here. This is a tumor in the gluteal fold, actually. And let me bring down the light here so you can actually see it. And this illustrates another feature that is much more common in lymphoid lesions in skin and not in leukemia cutis. And I actually can even go to even lower power here so we see both pieces here. And that is frank ulceration, necrosis, and epidermal repair, and here with a polypoid infiltrate. So this is typical of lymphomas involving skin and less typical of leukemia cutis. So if I just pull this guy up here, this is a case with a lot of similarities in some ways to some of the lesions that we're going to look at today, in the sense that very dark blastoid-looking cells. even hard to see in a lot of areas because there's so much crush artifact, hard to get appreciation of size, and there is some overlap. But the thing that distinguishes this from some of the other lesions we're going to look at, leukemia cutis, is this extensive infiltration and destruction of the overlying epidermis. And so this case here, I think I have some pictures we could show. So that's CD3 is negative and CD20 is negative. So you're like, what's going on here? What do an extended analysis, and CD4, which is in my core panel, which we'll talk about at the beginning, you start to pick up this dim staining. So raises the issue of plasmacytoid dendritic cell. It's dimly positive for 56 as well. So you're like, oh, is this plasmacytoid dendritic cell? But when you see this infiltration and destruction of the epidermis with a tumor-like lesion presenting de novo, you always want to think about anaplastic large cell lymphoma. And that's what this is. Anaplastic large cell lymphoma commonly is negative for many T-cell markers, as I think everybody probably knows, but often dimly positive for them. So in this case, dimly positive for 4 and also dimly positive for 56, but clearly not plasmacytoid dendritic cell neoplasm. So the key here is to focus on this ulceration. And pretty much anaplastic large cell lymphoma retains a lot of the features of lymphomatoid papulosis in terms of inducing this necrosis over the overlying epidermis, and that can be a very useful feature. So this patient, obviously not a derm emergency. This tends to be an indolent tumor that almost never spreads beyond skin. And, when you see this level of epidermal infiltration, the differential is tumor stage MF, and less so a systemic anaplastic large cell lymphoma, but still worth doing ALK to make sure that it's not an ALK positive ALCL when they present. And this patient did very well, topical treatment, clusters of tumors on the buttocks and gluteal cleft, but since excision and a little bit of single agent therapy, didn't have any recurrence. So can be 56 positive, but the key is to appreciate the top heavy epidermal ulceration.
Yeah, so this, that one? Yeah, I think this is a really great case because it illustrates that if we have this tendency kind of immediately throwing immunohistochemical stains on lymphoid infiltrates before we formulate our morphological differential diagnosis, we can go down the wrong path very easily.
Absolutely. And this looks very blastoid and very, worrisome. And part of it is there's so much crush because of the fibrosis. It's really hard to get that nice ALCL morphology, which can happen. So yeah, it looks a lot worse than it turned out being. And if you don't think about ALCL in this type of setting, then you may rely on the 4 and the 56 and say it's a monocytic tumor. But in fact, this dramatic difference, as we talked about, the monocytic leukemia is emergency, ALCL, one of the more indolent disorders that there is.
So. Yeah, so actually, Dan, you won't believe it, but you were teaching at the Dermpedia course when we did course on lymphoma. 3 days on lymphoma.
I remember that, Arizona. Yeah.
In Arizona, it was just quite amazing. And there's one thing that I still remember from your lecture, and you said something that really stuck in my mind, is that when we think about lymphoid infiltrates as dermatopathologists, there are 2 types. One is that we don't want to overdiagnose, and all the B cell and mycosis fungoides. And the other ones that we don't want to miss, right?
You mentioned my going to MD Anderson, which was a long time ago now, but it was in the modern era, and this was one of the things that had just started to dawn on oncologists, is that this entity here was incredibly indolent and shouldn't be treated with chemotherapy. So there were a tremendous number of patients in the late 90s, early 2000s that were still being treated aggressively for these lesions. And part of it is sophistication on their part, but a part of it was us communicating initially that these were probably worse than the. So I think This is a really important differential, ALCL versus leukemia cutis, and I have seen cases that have been misdiagnosed because of the CD4, 56, CD68 can all be positive in ALCL.
Mm-hmm. Here's a question from the attendee about whether what is the probability of having CD123 positive anaplastic large T-cell lymphoma?
That's a good question. So we did when we first developed our antibodies, we did a large survey, and there were a couple of cases. But when we look at one of the things about ALCL's positivity for a lot of these markers is that it tends to be blush, and the pattern is not typical. So CD123, by its name CD, you can tell surface marker, and so really strong BBDCN type of CD123 is that really strong membrane positivity. So that's really what you want to rely on for that kind of classic positivity. Once you start seeing cytoplasmic blush, Golgi staining, that sort of thing, then you worry a little bit about, is this just background staining? But ALCL is a very poorly differentiated T cell, so it does aberrantly express a lot of stuff. But obviously, once you have the CD30, that really screamingly positive CD30, that kind of puts you in the right mode, I think, to get to the diagnosis.
So then, you said we developed CD123. So was this done in your lab or?
Yeah. So when we and several other groups were developing markers, we made some monoclonals. Dave Mason made a bunch of monoclonals, and so that's why there are so many markers of this neoplasm out there, is because a lot of labs, when we were defining it, we made CCL1 at that time and showed that was a marker. So yeah, there are a lot of really good reagents, a lot of good monoclonals against these sort of second-tier markers for blastoid plasmacytoid dendritic neoplasm because.
So are we using your clone like now?
Depends where you buy it. So I think it would be a conflict for me to say who's.
Okay.
All right. So basically, here's let me get back out of here just so we can get a wider view. Here's our last kind of differential neoplasm here. And once again, I'm trying to get you the skin surface. You can see just how bottom heavy an infiltrate this is. And maybe a little less single filing in the areas where it's slowed, but there is a little bit of single filing. You can see it goes way down. So clearly this is an infiltrate we worry a lot about, but notice what it's doing there. It's hugging the adnexal structures. And then if we go down and look at the morphology on this guy, this is one I think we can go to high power and get a good look at it. Once again, really widely spaced cells, and very prominent nucleoli. So very different look than that kind of overlapping, folded, very irregular nuclei, very dark nuclei. This one is much more prominent nucleoli, very prominent nuclear membranes with clearing. And so this is kind of the classic appearance of what this actually is, which is negative for keratin, obviously very poorly differentiated. So, leukemia cutis was considered, and melanoma was considered, but this is diffuse large B-cell lymphoma. So this is probably the second most common heme malignancy you're going to see in skin, bottom heavy, but very, very large cells with prominent nucleoli. So different than the blastoid stuff that we're going to look at, and a lot easier to kind of see it. And this is one that almost never gets misdiagnosed because CD20 is in our core panel. This is CD3 over here, just showing that lots of admixed T cells in most large cell lymphomas, which is a kind of a useful feature to help stratify them. So those are the kind of lookalikes that are most commonly encountered. And then if we sort of come back to plastic plasmacytoid dendritic cell, we'll kind of see what we've learned from some of those other forays.
So Dan, while you
Yep.
are setting up, I would like to mention to the attendees something that is very important, which is that this series of workshops is supported by Stemline Therapeutics, and this is a company that developed a treatment which is now FDA approved treatment for BPDCN, and they found in their data that this disease is often misdiagnosed, either underdiagnosed or overdiagnosed, and they thought that this would be a good topic for discussion, and I entirely agree with that, because this is what we do at Dermpedia. We try to enhance the diagnostic skills of dermatopathologists worldwide, and I personally want to learn something while doing that. So we're really grateful for this support.
Absolutely. So this is obviously a much more dense worrisome lesion than the first one I showed you, is kind of an iconic, but same thing, much more bottom heavy. It's cut tangentially, so the epidermis is a little bit ragged from that, but basically intact pattern of keratinization, and that little bit of the Gren zone between the surface and so this is much more dense presentation, and you can see both the focal and we'll see a really focal one shortly, but that's kind of the iconic image. And then if we go down and do our look at the morphology, not the kind of separation that we were seeing with the large cell lymphoma or the tumor stage mycosis fungoides, and much more dark, very difficult to see the nucleoli in these cells, much more angry looking, what we call blastoid morphology, with that more smoothing of the nuclear chromatin, and quite a bit of irregularity. So when this is the picture with this dissecting pattern, very blastoid features, small as compared to large cell lymphoma, where we begin to say, okay, let's consider leukemia cutis. And that's where we have the algorithm. Usually you've got your CD4 maybe in your initial screen if you didn't think about leukemia cutis to begin with. And we'll just do low powers here because it's pretty clear what the answers are. So that is that CD4, strongly diffusely positive, and this is CD56, strongly diffusely positive. So that's kind of classic. That's what we're looking for in BPDCN, is that kind of level of positivity. But our differential would still include other tumors that are 4 and 56 positive, and the big differential here is monocytic leukemia. And so we talked before last time about my favorite histiocytic marker, which is lysozyme, because CD68 and CD163 lack specificity and lack sensitivity, actually. And here we have a beautiful example of total lysozyme absence. And then we talked before about almost all leukemia cutis in the skin is negative for 34, so it's a little bit of a waste of a stain, but unless you're considering other CD34 positive things, which of course do exist. So the one that tends to be good, you can either do myeloperoxidase or you could do CD117 as a good myeloid marker kit. And in this particular case, totally negative for CD117 as well. So our differential of monocytic versus plasmacytoid dendritic cell neoplasm established now with the absence of lysozyme. And this patient went on to have, like many of these patients, a very, very aggressive course, became leukemic within a few days, and had extensive lymphadenopathy as well, too. So that might be a good time, Artur, to turn it over to you to talk a little bit about cases that you've seen.
Well, I just only had one case that I really wanted to show. So then this is that biopsy, kind of typical derm path case, shaved.
Yep.
And there is this epidermal hyperplasia, which kind of goes a little bit against, if we were to consider leukemia here, against that a little bit. But
I think it was a fairly traumatic biopsy as well, too.
Yeah, that's true. And we have this infiltrate right there. You can see. That looks ugly, but it doesn't look that blastic, does it?
No, very abundant monocytic-looking cells, right? Sort of almost histiocytic.
Yeah, so abundant cytoplasm, kind of a little bit eccentric nucleus, isn't it? Right. And that's, I think, the step in dermpath we always have to do just to establish this morphology. It seems to me. Actually, I can go even higher power. A little bit, yeah. And then, when I look at those cases, I don't have that kind of strict algorithm that you have, but I was just curious, if we were to apply your algorithm that you suggested, what will be, the process, the diagnostic process of immuno? So then, the stain number 1 that Dan uses, this is CD3. So we have a little bit of CD3 positivity there. The second first tier immunohistochemical stain is CD20, right? Then we have CD4. Maybe, it is positive and in those cells of interest, right?
It's actually got sort of two-toned expression.
There's a two-tones expression, yes. There's a dimmer and, right? And some smaller cells seem to be more positive. Then the stain number 3 in Dan's first tier is myeloperoxidase. So there's some neutrophils there too, but looks negative, doesn't it? Mostly.
Yeah, mostly. A few kind of immature cells are hard to know what they are, but yeah, mostly negative. Yeah.
And then we have keratin, S100. So Dan always uses keratin and S100 to exclude other possibilities. And we have S100 that is positive. And that's always S100 always elicits interest of a dermatopathologist because of, could this be a funny melanoma? Yeah, and that's probably why you have that in your first tier inbox, Dan, isn't it? Right?
Yeah, it is. I think obviously, when you're thinking heme and you're thinking stuff, especially in this area of the skin with epidermal involvement, then you want to consider true dendritic cell neoplasms as well. So
and the dendritics, so you like Langerhans cell, and so this is the tier 1. So what would be the next step? To me, as a dermatopathologist, I would certainly do Melan A and SOX10. I'm showing this to you. And I have, SOX10 that's negative. So we pretty much excluded that melanoma idea. So where would you take this case from now? Then, what's the next step in your algorithmic approach to immunohistochemistry?
Right. So as we talked about, obviously the appearance of the cells is very histiocytic, and the dim CD4 expression or two-tone CD4 expression does raise the issue: can we definitively establish a dendritic cell process? Included in that second tier, I always put CD138 because plasma cells are our famous mimic. Now, obviously, this pattern isn't very good for that, but so the key to sort of definitive monocytic, histiocytic lineage is lysozyme. So lysozyme would be a very important next marker to do here. And then, I think we kind of regroup a little bit based on
what it shows. Yeah.
Yeah, what it shows. As we talked about, CD30 could always be considered here with CD4 positivity. So that would be in the tier here. So I think tier 2 would break down a little bit here because it is such a large, mature-looking population. So I would add CD30 to this one for sure.
You mean CD30? Yeah. So, well, I didn't follow exactly your protocol, but I always have in my protocol. Actually, I always do CD56 on anything that is cutaneous because of other kind of almost automatically. So I will start showing you with CD56. So this is CD56, Dan, and I think that really is a good. So we have CD4, CD56 positive neoplasm, and I think one of the important points here is that in addition to BPDCN, we have to consider other neoplasms in our differential when we have this a pattern of staining, right? And so I mean, I always have both CD4 and CD56 in my initial panel, right? So, but as you said, I didn't do CD138. I have CD30 as well, which is negative. I'm not sure if I can quickly. Yeah, I'll show it. Yeah, so this is, CD30. Yeah, so I did not do plasma cell stain in this case, but that's something actually I will, incorporate because I think this is something that, new to me. To do that, but I think it makes perfect sense. This is TDT, so this is also a stain, one of the stains in your second tier.
Right. And here, given how mature it looks, it would just be, I might tweak it a little bit. So
you would skip that. Yeah. Yes. In your and then we come to this myeloid monocytic. Stains, and this is CD. Actually, this is lysozyme.
That's pretty impressive. It's got dot-like staining, huh?
Yeah. So this is a dot-like staining, right? And then I have CD68.
So the chat was wanting CD1A. Did you do CD1A?
CD1A was done and was negative, but that was a good. It's negative. I don't have it here. And then the next group of stains that you do are CD43, CD34, and CD117, right? That kind of myeloid. So this is CD43. CD34 negative and CD117 negative. So pretty much I think without additional stains, we can probably stop here. But we did, but I think in any case, it would be a very reasonable thing to follow up with BPDCN markers, right?
Yep.
And so this is one
So I
CD20.
think yeah, you did more here. Which one is it?
Yeah, this is CD123.
123. Okay.
Mm-hmm. Even though morphology, I mean, is not typical, it's not blastoid. I think having that.
Well, we were talking about reactive or neoplasm-associated plasmacytoid dendritic cells, and this one actually has them. Those are reactive plasmacytoid or tumor-associated. Right. If you go back to that area, there were some nice, there were some nice ones with very abundant cytoplasm, very benign looking. I think down towards the bottom somewhere.
Right. This is TCL1.
Oh, TCL1, yeah.
Yeah, I switched to TCL1, and yeah. So here there are some reactive. This is back to CD113. Sorry, CD123.
Mm-hmm.
Okay. So
yeah, I mean, I think that brings up the really important differential of once you have the 4 and 56. The single most important thing to do, I think, before you sign it out is lysozyme. Because lysozyme is a terminal differentiation marker. In this particular case, I think it was so histiocytic looking that you'd want to kind of do the more extended workup that you did just to make 100% sure. But I think I sort of don't feel comfortable making a diagnosis of plasmacytoid dendritic cell neoplasm without having done a lysozyme to exclude that strong positivity isn't a monocytic phenotype as well.
Mm-hmm. So I will contrast morphology of this case with this case.
So the question is, I think this is good. We had some questions about that maybe before we get to that. Artur, somebody asked, so is it chronic myelomonocytic leukemia? So this, I think you're going to have a case showing here that might reveal some of that issue. But I think this is where we talked about last time that it is not 100% possible to differentiate between acute monocytic leukemia and CMML on a biopsy, but the heterogeneity versus uniformity is going to be one thing we're going to lean on a lot. And this was a very uniform type of lesion. But I think the question of what to call it, I think I'll probably close here with a case of chronic myelomonocytic leukemia just so we can kind of contrast that. But this kind of sheet-like, very histiocytic looking tumor, that's going to be acute monocytic leukemia. So that's just kind of a presentation. And those of us remember in the old days of medical school, they showed pure acute monocytic leukemia produces hyperplasia of the skin. Gum hyperplasia is famous. And I think that would bias me towards saying this is going to be a presentation of acute monocytic leukemia as opposed to chronic myelomonocytic. But as we talked about before, the job is just to call it leukemia acutis and then stage blood and bone marrow. So I think that's probably as far as we need to go. But you're gonna go for acute monocytic leukemia almost certainly.
Yeah. So that morphology contrasts with morphology of Blastic plasmacytoid dendritic cell neoplasm. I just wanted very briefly to show a case that's more subtle, and for dermatopathologists can raise a broader differential diagnosis that may include tumid lupus, for instance. Yep. And as Dan mentioned, even at low power, we can see that there's a lot of artifact, molding,
crush, a lot of crush too.
A lot of crush.
Yeah.
And here is the morphology of this very irregular, medium size to small cells, blastic, not much cytoplasm, right? So I think that's the kind of key morphological
Yeah,
differential.
very,
That,
very smooth chromatin, very indistinct nuclei. So it's very,
hmm
very good case. This one looking more
Right,
like an acute leukemia, very aggressive looking, obviously. Yeah.
right. And I think that what is important is just to remember that morphology, because sometimes in the subtle cases we have to consider diagnosis of BPDCN when the infiltrate is not that prominent. So yeah,
For
yeah.
sure.
Okay, then I think I will hand over back to you.
Okay, maybe I'll just to address that issue a little more deeply. The issue of once you've decided it's monocytic, what do you call it? And so there was a question. Maybe we can comment on before we show this next case. Is lupus has lots of CD123 positive cells. Would it be hard to differentiate lupus with blastoid, plasmacytoid, dendritic cell neoplasm? What would you say about that?
Oh, for sure.
Yeah, I think the main thing is the morphology. So the case that Artur was showing actually had a nice little cluster of 123 positive. The first case that you had.
You're the first.
Yeah, if you go back to your 123 on that on the monocytic leukemia,
Here it is.
I think you'll see, yeah, that cluster right there. Yeah, if you go down on that, you see many of these cells have very benign looking cytology with almost like a fried egg appearance. So those are benign plasmacytoid dendritic cells. So very classic appearance.
Let me see if I can find them on H&E. No, that would be very hard. Huh?
It's a good try, though.
No, there's no way. Okay. Yeah.
All right, so I'm going to steal it back here and show. Okay, so this, in a lot of ways, and I think I can go back down to even lower power just to give people a sense of where this thing is, has somewhat of a similar distribution in the mid-dermis, relatively dense, as Artur mentioned, could be a lot of different things. But you see in this case, the epidermis maybe has a little bit of regenerative changes, but largely uninvolved by this process. And then if we go down and take a look at what the components of this infiltrate are, in contrast to the one we just saw, it's a lot harder to say what these cells are. Very polymorphous, a lot of cells with abundant cytoplasm. But as we go through here, I think the key that hematopathologists tend to focus on a lot is, are these irregular cells scattered throughout that make us think this is probably a neoplastic process? And we'll go down and look at them a little bit more at even higher power. And they're just, some of them are clearly more mature histiocytes, very, very twisted nuclei, a lot of lymphocytes in here, maybe a few granulocytes mixed in. And then these cells, which we're not 100% sure what they are. Some of them have little notches in them. So with this infiltrate, it's pretty broad differential. You'd want to include sort of a histiocytic-rich T-cell lymphoma, I think, would come into the differential, possibly some sort of T-cell-rich, histiocyte-rich B-cell process. And then are the histiocytes are they the neoplastic component here? That would definitely come to mind for me. Okay, this was a 70-year-old, by the way, who had these little papules. Okay, so then if we work through our initial set of stains, so this is CD20, so there are actually some CD20 positive cells there. Some of them are dermal dendritic cells, some of them are small B cells. This is our CD3, a lot of CD3 positive cells, but you can see most of them are actually small, but really abundant CD3 positive mixed in. Okay, I said don't bother to do CD34. It wasn't my case, so somebody did CD34, but they're not blasts. And then we did CD4 in the basic panel to pick up a variety of different things besides. So you see the T cells are strongly positive, and in the background you see all that histiocytoid stuff that is weakly positive. And so next here, CD117 and lysozyme, and you can see that if we go down and look at, and this is where you have to kind of, it's a little bit of a sloppy stain, but you have to kind of work with it a little bit. In contrast to Artur's case, which was uniformly strongly lysozyme positive with that dot-like staining, here we get a much more atypical distribution. But if you look at some of the positive cells, I think I'll go down even higher here, you can see that they include a lot of the cells that we were worried about, these irregular, more immature cell types. Okay, so there's kind of lymphocytes, and then there's these cells, and they're pretty much scattered throughout this whole infiltrate, and they even drift out into the interstitial areas. So this was a difficult case because it's so polymorphic, and genes were done on this, and this is a case that had multiple myeloid-associated mutations and was correlated with blood criteria for chronic myelomonocytic leukemia, with I think about 5,000 monocytes in the peripheral blood per microliter, including immature forms, and the bone marrow had monocytes in dysplasia. So this is the pattern that you tend to see with chronic myelomonocytic leukemia. It's a lot more painful and difficult to get to a diagnosis. If you're having an easy time and you get that uniform lysozyme, that's where you're going to think this is probably the presentation of acute monocytic leukemia. So I think it's a nice contrast with Artur's case, where much more polymorphous, you really have to work. And the key is not just to do the stain and see that they're cells, but actually kind of appreciate the immature. These are not truly recognizable as monocytes or histiocytes. They're more immature myelomonocytic forms, and they're greatly admixed with reactive lymphocytes, but in fact they're everywhere in the lesion, and you can go anywhere in the lesion and see that they're there. Okay, so chronic myelomonocytic leukemia tends to be those cases that give you a little bit more of a headache in terms of getting to a diagnosis, and is relatively common. So this is the one that I think most frequently gets not diagnosed for a while. It's just called a mixed histiocytic infiltrate. Whereas if it's acute leukemia, and this is a case of acute monocytic leukemia, which is very sparse in this biopsy. You can see here, it's really only around, a little diffusely here in the dermis, and then just around the adnexa. Not much happening deeper down or above. But if you go down and you look at these cells, and remember that's the theme for the day, go down and look at the cells at high magnification as you're comfortable with. They are very irregular and very overlapping and very blastic in appearance. So this case was actually just signed out as, I think, a typical mononuclear infiltrate, and even despite the fact that it had this CD56, which is quite impressive. One second here. sure we'll get into that. Pretty small. I'll just show it on its side here. Very impressive CD56. But 2 weeks later, there was a large subcutaneous nodule excised, and this is what it looked like. So sheets all the way up, all the way down of immature myelomonocytic forms. Very blastic looking, dissecting through collagen. Very ugly, high mitotic rate. Here we get a little bit more prominent nucleoli in some of the cells. And so that's what acute monocytic looks like. Acute monocytic leukemia looks like. So we call it a derm emergency because we went from a superficial biopsy with a fairly low-level degree of infiltrate, still atypical, and then 2 weeks later we have these large masses taking over. So much more uniform, much more aggressive in appearance, and of course that correlates with a more rapid progression. So chronic myelomonocytic leukemia can go on for several years with these low-level mixed infiltrates. Acute monocytic leukemia, if it's not diagnosed and treated within a couple of weeks, will take over with these types of enormous infiltrates, as will Blastic, Plasmacytoid, Dendritic cell Neoplasm. So both of them just progress a lot more quick. So that's a little bit more about what I would consider a large cell lymphoma-like appearance, but I guess the key to seeing it as blastic is that we do have these smaller cells, and we do have some molding in various areas as well too. And so that's a kind of a good image of the difference between chronic myelomonocytic leukemia.
Then,
yeah.
So even with those large cells, you still pay attention to those smaller cells.
Yeah, I think the key is to appreciate what we call the irregular nature of leukemia cutis. So you're gonna get the full range of maturation in most cases. Mm-hmm. You happen to have a monocytic leukemia that was kind of fully mature, if you will, still leukemia, but fully histiocytoid. But most of them will show a much more variable degree of maturation from more blastic cells to a little bit more mature.
Especially when they go to skin, when they tend to mature. Right?
Absolutely.
Yeah.
So this is a fairly unsubtle blastic plasmacytoid dendritic cell neoplasm. Once again, though, showing relatively uninvolved overlying epidermis and the full thickness involvement. So it's hard to appreciate any features of sort of single cell infiltration because it's kind of taken over. And this is a kind of case that was the reason why this was originally called NK cell lymphoma, because this is very lymphoid looking in its appearance. But I'm showing it not so much for the morphology, although we'll take a look here at the morphology. I'm showing it just to talk a little bit more about phenotype. So we go to higher power, we see this overlapping of cells, this molding, this very dark, highly folded appearance. So looks very aggressive. So small, lymphoid looking, but really marked irregularities in the cells and notches and all that kind of thing. Okay. And this is just to come back to the issue we talked a little bit about last time. So basically, classic phenotype, here's 56, here's 4, negative for 3, So nothing atypical about the phenotype. But this is one of these that has S100 expression fairly diffusely. And so we had a bunch of comments in the chat last time. About 25 to 30% of blastoid plasmacytic dendritic cell neoplasm is S100 positive. Tends to be younger patients. But one of the interesting things that we noted when we first reported this along with other dendritic cell markers is it tends to be inversely proportional to TDT positivity. So TDT is positive in about half of plasmacytoid dendritic cell neoplasm, but the number of positive cells is highly variable. And pretty much every case will have at least a few TDT positive cells, but this case had almost no TDT positive cells, just a few scattered here or there. So this is really to say that just like monocytic leukemia, where we saw this case of Artur that was very mature, and we saw the case that I showed, which is much more immature, much more blastic. Plasmacytoid dendritic cell neoplasm does the same thing. It has more mature variants, less mature variants, and the mature ones tend to be the S100 positive ones. And the TDT positive ones tend to be the ones that are much more acute leukemia, blastoid looking. So that can be helpful just in kind of putting into context a little bit some of the abnormal patterns. So I'll just close just to give completeness to our discussion with, we talked about monocytic leukemia as leukemia cutis, and of course you can get lymphoid leukemia as well. And how to tell that apart from lymphoma maybe is kind of a useful thing to just think about. Okay, so this case basically over here has pretty much normal epidermis, normal dermis, and then we've got something in the subcutis. And then over on this piece here, it's going up into the dermis, or at least maybe some entrapped superficial subcutis. And if we look at the morphology of these cells, they're very small. Oops. Very small lymphocytes. But we have all of the features that we've come to recognize for these blastic infiltrates in skin, which is they're very dark, a lot of crush artifact. And if we go down in areas that are better preserved, well, this area here we can see, as you're seeing through the cells that are crushed and the cells that are too dark to see, we see these cells which are small but very convoluted. Okay, and so this is a classic appearance in this case of B-cell lymphoblastic leukemia involving skin. So leukemia cutis, but in this particular case, the phenotype is B lymphoblastic. And B lymphoblastic leukemia involving skin is usually an elderly phenomenon. Most pediatric cases don't involve skin, although of course they can. But in this particular case, this was a younger person who presented in this manner. All right. Do you want to go through the chat a little bit and see if there's any things before we quit?
Well, I don't see many questions.
Somebody asked, in cutaneous large B-cell lymphoma, do you report the presence or not of germinal center phenotype? And we do. We report, although as you probably know, most skin lymphomas, large cell lymphomas, are of the non-germinal center phenotype. So we do the 3 stains, CD10, BCL6, and MUM1.
More questions?
All right, so my 3 take-home points are go to high power, worry about infiltrates that are more bottom-heavy, and always consider monocytic leukemia before you make a diagnosis of blastoid, plasmacytic, dendritic cell neoplasm.
Mm-hmm. And I think another thing is to use immunohistochemical screening tools when in doubt, right? To really,
Yep. And we made a comment before about don't rely so much on Ki67 to tell the difference between a high grade and a low grade, because a few doses of steroids can do a lot to the Ki67. It's obviously helpful. If you have a very high rate, you're gonna be thinking high grade, but rely more on the morphology, the blastoid morphology, the pattern of infiltration, single file pattern, and of course the immunoprofile.
Okay. So thank you very much.
And thanks to everybody for joining, and have a good rest of the day.